Dr. Gigi will tell us about whether he would like to order investigations to evaluate the underlying ischemic heart disease or not. Commonly we see diabetes patients, we always order ECG, and beyond that, what else for the diagnosis of ischemic heart disease? Dr. Gigi, please. Good friend of mine for nearly 30 years now. Worked in St. John's, went on to join NH, and where he is quite well-niched practitioner. Professor Gigi Shetty, please. Thank you so much.
Thank you, sir. I feel it an honor to be here. Well, I'll also promise I'll give you 3 minutes. Well, this is the first slide. My topic is to evaluate or not for myocardial ischemia. So, important one is whether to evaluate for myocardial ischemia and coronary atherosclerosis in newly diagnosed diabetics. So, very focused approach. Can I have the next? Is it here? Next slide. Well, when I got this topic, I knew it would be a googly. I always expect that. So I asked for some help, and he sent me these 2 articles. One was which was published in Circulation, the second one in 1996 June, both of them speaking on silent myocardial ischemia. The second one is a recent article which was published on January 2022. So with this article, I was trying to understand what are the known facts about coronary artery disease. So coronary artery disease is a major complication of diabetes. And what is important is nearing 50% of the deaths in diabetes occur because of coronary artery disease. So it is not something which you can take it lightly. Diabetic patients have an early onset and a more extensive atherosclerotic disease, especially in the coronary arteries. Myocardial infarction in diabetic patients is more extensive and has a higher mortality. Silent ischemia is a real problem in diabetics. And then the third sentence is even more important. By the time you diagnose diabetes, already the metabolic abnormalities of diabetes have already set in, and the macrovascular disease would have already started appearing. So trying to make a diagnosis with the present criteria and then evaluate may be a little too late. With silent myocardial ischemia, well, you know, people with diabetes can have silent myocardial infarction. There is a 3-fold increase in cardiac deaths in patients who have silent myocardial ischemia. So keeping these things in mind, I was searching for an article, and I came across this. In 2023, European Society of Cardiology, I want to emphasize on the word cardiology, it is not a diabetic association guideline, it's a cardiology association guidelines for the management of cardiovascular disease in patients with diabetes. This is a 96-page guideline which was published on 15th November 2023, and all the data was compiled from January 2020 up to January 2023 was used to publish these guidelines. So quite an extensive one, and they emphasized on the evaluation, diagnosis and treatment of diabetics in patients with cardiovascular disease. The section 4 of this particular guidelines emphasized on the evaluation of risk assessment in patients with diabetes. And this statement is as it is in the guidelines. Patients with diabetes are at an increased risk of developing cardiovascular disease, and they can manifest as coronary artery disease, heart failure. The presentation can be as coronary artery disease, heart failure, atrial fibrillation, stroke, aortic or peripheral artery disease. And this can be a first manifestation even before the diabetes is diagnosed. Many patients with the above complications may have undiagnosed diabetes when they are presenting with this. So it is utmost importance, the same words I've used, it is utmost importance to assess cardiovascular risk in individuals with diabetes. Evaluate them for cardiovascular and kidney disease. So I've highlighted those. So the answer to the question, we have to evaluate patients with cardiovascular disease and kidney disease. And what is new? There are 3 guidelines that have been given. I'll be very brief. I will not sidetrack the things. 3 guidelines have been given in this particular chapter, that is the section 4 of the guidelines. The first one is, in patients with diabetes without symptomatic ASCVD, it is recommended to estimate the 10-year cardiovascular risk with this new score. This is the score to diabetes, which is being published and highlighted upon in this particular guidelines. So we have to, and the level of evidence is 1 with class 1, level B evidence. So we have to use this score to diabetic score. And what is the score to diabetes? The aim is to estimate the 10-year risk for fatal or non-fatal CVDs, that is either MI or stroke. And they have classified them as, the score can be applied between 40 and 69 years. And those who are above the age of 70, the score to OP has been used. Previously, some other scores were used. I'll skip that. That was up to 2021, the advanced dial and dial 2 were used. And then these are the parameters that have been used in the score. Age, smoking, systolic blood pressure, total cholesterol, HDL, age at which the diagnosis was present, HbA1c and AF. Conspicuously, you can see that this was a European Society of Cardiology guidelines, and the cardiac parameters are not been used in this. And how to assess the score? There is an app which is which is there in the European Society CVD risk calculator, and we use this app. We have to download this app and then assess the risk. According to this, 4 classes: very high risk, where there is already target organ damage and there is established coronary artery disease, ASCVD, and the risk is about 20%. Whereas the other 3, high, moderate and low, they don't have established coronary artery disease. However, the risks are high. And these are the ones which we'll have to evaluate. This is the picture, and this was validated in approximately 230,000 patients in the European, this is the European guidelines. They have used Sweden, Spain, Malta and Croatia patients. And it is further also classified differently in men and women. So the other use of the risk, this score to diabetic risk is one guideline. The second guideline they have given is, it is recommended to screen patients with diabetes for the presence of severe target organ damage. This target organ damage can be anywhere. So the class 1, level A. This is the highest. So investigating patients is class 1, level A. And the next recommendation, it is recommended to assess medical history, presence of symptoms of ASCVD in patients with diabetes. Something Dr. Desai will be very unhappy with. Investigation is class 1 and A, and then taking history has become class 1B. So don't blame if somebody asks for the investigation first and then takes the history later on. Okay, this is assessing the risk in patients with, so you have to take the medical history, family history, symptoms, examination. This is very clear. And next, the laboratory tests also are accepted. Diagnostic tests are also accepted. To classify them as very high risk, we have to look for the presence of ASCVD and target organ damage. They have defined the renal target organ damage, that is GFR less than 45, urine albumin creatinine ratio more than 300, or a combination of these, presence of vascular disease in 3 bedsides. However, they have not defined what has to be done for the cardiac patients. What not to do, they have emphasized. Coronary artery calcium should not be used. There is no validation, or intima medial thickness. Both are not permitted. And then sir had sent me, what will you do? So I have created this one slide. I would want to do an ECG and echo, although the guidelines are silent on this. TMT plus or minus. Whereas the other costlier investigations, MPI, stress MRI, or CT-CAG, I wouldn't do in a routine case. Only if additional indications are there, then I will go for these tests. So with this, addressing the given question, to evaluate or not for myocardial ischemia or coronary atherosclerosis. For ASCVD, yes, we need to evaluate, and it's a class 1B indication. And for reversible ischemia, no. It is dangerous to wait, of course, for the symptoms in patients with diabetes.
Wonderful, excellent. Although I must confess that you did not give me any time.